Good afternoon, one and all. I welcome all the online participants and the offline participants and NIPID faculty and the staff who are attending this national webinar on understanding and management of schizophrenia. As you all know that every year on May 24th, we are celebrating World Schizophrenia Day to create awareness among the general public, parents, students, teachers, and the rehabilitation professionals. So as per the instructions of ministry, today we have done a national webinar in two settings. In the morning, we have done in the Hindi webinar with the speakers, experts in the Hindi. So we have got a huge responses. In the morning, we got around 623 people watching in the live YouTube streaming regarding the Hindi version. And also we have more than 340 participants who have joined in the Google Meet link. So the main agenda for organizing this webinar is to understand what is schizophrenia. So what are the risk factors, what are the symptoms, and what are the early warning signs, and what are the different types of schizophrenia, and also what are the causes. So many having doubt what are the causes for schizophrenia, what is the presentation, what are the comorbid conditions which present with schizophrenia, and also the management part, which is very, very important, and the rehabilitation part. So we are having a very good speakers since morning. So we are having very wonderful speakers since morning. We have enlightened us. They have given very wonderful presentation. Now also for the English version, we are having very young and dynamic two speakers. So our first speaker is Dr. Devika Kosana. She will be talking on understanding of schizophrenia. So what is schizophrenia? What are the risk factors? What are the symptoms or what are the types? And she will be talking very briefly on understanding of schizophrenia. So regarding the introduction of the speaker, Dr. Devika Kosana did her MBBS from Gandhi Medical College, Secunderabad, and she has done MD Psychiatry from AIMS India, New Delhi. That is All India Institute of Medical Sciences, New Delhi. She worked as Assistant Professor of Psychiatry at NIPID, Secunderabad, and also she worked as Senior Resident at Institute of Mental Health, Erragadda, Usmania Medical College, Hyderabad. Presently, she is working as Assistant Professor of Psychiatry at ESA Medical College and Hospital, Sanatnagar, Hyderabad. And she is a recipient of the Old Psychiatric Association AFPA Scholarship in 2022. She has published numerous papers in national journals, and she is also peer reviewer for several journals throughout the country. She was a speaker at national and international level, and she has contributed several rehabilitation as a speaker as a CRE webinars, which are recognized by the RCI. She was a member of Indian Psychiatric Society and IPS South Zone and Indian Association of Suicide Prevention, and also APSI and Hyderabad Psychiatric Society. Our areas of interest include child and adolescent psychiatry, general adult psychiatry, and women's mental health. So with this introduction, I welcome our speaker, first speaker, Dr. Devika Kosana. Madam, handing over to you, Devika.
Wait, Obi.
Dr. Devika, can you hear me? Dr. Devika, unmute yourself. Dr. Devika, can you hear me?
Yes, sir. Now I could unmute my mic.
Okay. So Devika, we have introduced yourselves to all the online participants and the offline participants, NIPID faculty and staff. Okay, no? You can start your presentation.
Yes, sir. Thank you, sir, for the kind introduction. And good afternoon, one and all. At the outset, I would like to thank the organizers for having me here to spread awareness about schizophrenia on the occasion of the World Schizophrenia Day. Sir, is my slides visible? Are my slides visible?
No, ma'am.
No, ma'am. No. No, ma'am.
Yes, I am, ma'am.
Dr. Devika, we are sharing your presentation. Okay, any technical issues? Our team is sharing. Okay, now you can go through it.
Okay, sir.
Hello, Devika. Dr. Devika, if you can hear me, please start. It is visible.
Devika, we have shared your presentation. Our team is sharing. Okay, now you can start your presentation.
It's not visible on the screen, sir.
No.
Okay, yes. Now it's visible. So, sorry for the technical glitch. So, good afternoon, one and all, once again. And since this talk targets a wide range of audience, including general public, caregivers of persons with schizophrenia, then special educators, teachers, clinical psychologists, and other mental health professionals, and also other health professionals. So I'll be beginning right from the basics and will move on to some details of schizophrenia. So I'll be covering this talk, starting with the need for celebrating the World Schizophrenia Day, then regarding some of the myths and facts of schizophrenia, a brief overview, epidemiology, and the causes of schizophrenia. I'll be stressing on the clinical features because one needs to identify these features early and encourage people to take attention on treatment on time. So then about the management. So next slide, please. Can I have the controls of the presentation? Can I have the controls of the presentation?
You can tell next slide. Our team will be changing. Okay, no? Like you can tell next slide when you want. Okay.
Okay, sir. And there's some animation, so I'll just say next.
Yeah.
Okay. So the World Schizophrenia Day is celebrated every year on the 24th of May to generate awareness about this disorder, to reduce the stigma and discrimination, to eradicate the myths surrounding schizophrenia, and to encourage individuals to seek timely management and care in order to lead a fulfilling life. Next slide, please. Next slide. Can I have the next slide, please? So here are some of the myths and facts of schizophrenia. Next. Next, please. Excuse me. The slide is, the animation is not visible. The previous slide.
Animation is not coming in your PowerPoint, Devika. So the next slide is the introduction slide. What we are able to.
I mean, at least can it be played without the animation, the full slide?
Go back. Gautam, go back. Back. We are not able to see anything except that myths and facts. No other content we are able to see on the tablet.
So can I share the presentation once again with you then, removing the animations? Because in my screen, it's showing the correct one.
Our technical person just now went to other meeting. So you can continue in the last, we can share this one slide, I think. Okay.
The other slides also have animation. So if you can permit, sir, I'll share it again without the animation, sir.
Devika, you
Can I
can
have
share your
2 minutes, please?
We have started, you start sharing your screen.
You can take admin rights, ma'am.
Devika, we have stopped sharing, so you can share from your side, okay?
Okay, sir. Thank you. So is it visible now?
No, ma'am.
Is this visible?
Not yet. Not yet, ma'am.
No, madam.
No, not yet.
No, ma'am.
No, ma'am.
No, madam, only visible your face, madam.
Yes, no, it's visible. Yes, it is
Okay.
visible.
Okay. So, okay, I'll
Schizophrenia.
So here are some of the myths and facts about schizophrenia. So these are myths that it is caused by black magic or evil spirit. So in fact, schizophrenia is just like any other disorder. So it is a chronic brain disease. So schizophrenia is not a person's fault or moral failing. It is just like any other disease such as hypertension, diabetes, hypercholesterolemia. So it's a myth that only weak people develop it. In fact, all of us are at risk of developing schizophrenia. Schizophrenia is a multiple personality is a myth. The term schizos means split and phrenia means mind. So initially it originated as split mind. The meaning of it is that person cannot distinguish what is false from the reality. So that is the meaning of split mind. So schizophrenia cannot be treated as a myth. In fact, currently we have effective treatments for schizophrenia. Individuals with schizophrenia have to be chained or kept in mental hospitals is a myth. Currently, we have effective treatments using which humane and community-based treatment is advocated. Individuals with schizophrenia have to take medicines lifelong is a myth. The duration of treatment depends on multiple factors, including the age of onset of the illness, the number of years that the person is having illness, number of years the person is not treated, number of episodes, and so on and so forth. So the other myths are medicines can be stopped once the symptoms reduce. But the reality is that once the medicines are abruptly stopped, the risk of disease recurring is very high. So one has to discuss with the psychiatrist before making any changes in the dose of medications in order to avoid the risk of relapse. Individuals get addicted to these medications is a myth. These medicines do not have any addiction. It is just like your antihypertensives or drugs to treat diabetes, cancer, etc. So therapy and counseling is adequate and there is no need for medicines is a myth. The reality is that medicines are the mainstay of management. However, we need both medications and therapies to get optimal results so that the patients lead a productive life. So it's a myth that once a person is diagnosed with schizophrenia, their entire life is ruined or they'll lead a miserable life. Now, with the currently available treatment modalities, individuals with schizophrenia can lead productive and fulfilling life. So it's a myth that individuals with schizophrenia are dangerous and they are highly violent. On the contrary, the individuals with schizophrenia who are on proper treatment are not at a higher risk of violence when compared to general population. So now that we have eradicated a few myths about schizophrenia, let's move on to the introduction of schizophrenia as an overview. So schizophrenia is a chronic brain disease. It's a serious mental disorder which has a long course and has significant impairment of functions. So there is changes in the perception, thinking, cognition, emotion, and behavior of the person. So schizophrenia affects all aspects of the person's mental functions. So according to the DSM-5 given by the American Psychiatric Association, schizophrenia is diagnosed if there are delusions, which is a disorder of thought, wherein the person has a false, firm, fixed belief, which is out of keeping with the person's socio-cultural background and is of morbid origin. So to put it in simple terms, delusion means that there is an abnormal thought, the belief that which is wrong, but even despite giving evidence to the contrary, the person holds it. So for example, a delusion of persecution. So if the person says that everybody is out there trying to kill them, which is not the fact, but even after his family members try to show them evidence that nobody is trying to harm them, still they continue to believe it. So this is delusion of persecution. Coming to the second symptom, the hallucinations. Hallucinations are disorder of perception. It means that when there is no stimulus, still we are perceiving. So perception without stimulus is a hallucination. So to describe it simply, for example, there is no person, but a person with schizophrenia is able to see a person. So that is called hallucination. That is, there is no object, but he's able to see an object. Then the third one is disorganized speech. So a speech is a window into the thought process. So this implies that there is disorganized thought also. That is, there is lack of continuity of speech. So when we are speaking, one sentence is connected to the next such that there is a meaning. In these, there is a loosening of association. The continuity is lost. And also persons might use new words which are sort of abnormal, and there are many more which I'll be discussing in the next slides. So schizophrenia is characterized by grossly disorganized or catatonic behavior. So here it means that the person has very impaired self-care. So not bathing, brushing, combing, or having food, so catatonic behavior refers to a state of reduced activity, and I'll be discussing it in detail further. And negative symptoms. So out of these 5 criteria, at least 2 must be present, and the 1 criteria must be there from the 3 in the first row. So this should be there for at least 1 month, and the person should have significant dysfunction for the last 6 months at least. So this is diagnostic, then you can call it schizophrenia. That too if it's not caused by some other medical condition or under the influence of substance. So classification of symptoms of schizophrenia. Symptom means the complaint or what you see in the patient. So there are 3 major types. positive symptoms, negative symptoms, and cognitive symptoms. So positive symptoms refers to this symptoms which are not seen in normal people, but which are present in these individuals. So the delusion, the hallucination, which I said previously, are not seen in normal people, but it is visible as an extra feature. So those are positive symptoms: delusions, hallucinations, disorganized behavior, okay, the disordered thinking. So all of these are positive symptoms. Then negative symptoms. Negative symptoms means the features which are there in normal individuals are either reduced or absent in individuals with schizophrenia. So something which is not there up to a normal level, less than normal, is negative symptoms. For example, all of us interact with other individuals in the society. We like doing certain activities, and we enjoy doing certain activities. So in these individuals with schizophrenia who have negative symptoms, they don't like interacting with people, so reduce social interaction. Then anhedonia, which means they do not get pleasure out of the routine day-to-day or activities which they used to like earlier. So there's reduced speech and all. These are negative, some of the negative symptoms. Next are cognitive symptoms. Cognitive symptoms refers to an impaired concentration, attention, memory disturbances. So persons with schizophrenia will have difficulty in processing speed. That is, when you listen to something or read something, you need to process to understand the thing. So that capability is also reduced. So these are higher mental functions. The mind functions are being impaired. Then they may also find it difficult to take decisions, solve problems. So all of these put together, cluster of positive, negative, and cognitive symptoms can be seen in schizophrenia. So the next, coming to the epidemiology. In India, there is approximately 0.4% lifetime prevalence of schizophrenia, according to the National Mental Health Survey of 2015-16, conducted by NIMHANS Bangalore. So what does this translate to? That is, 1 in 250 individuals in India have schizophrenia, approximately. So that is roughly about between 50 to 60 lakh individuals. And the treatment gap is 75%. Which means that out of every 4 individuals who have schizophrenia, 3 of them are not receiving treatment. So this shows the great magnitude of the problem. So the reasons for non-availability or non-seeking of treatment are various. Like, for example, the lack of awareness about the illness. So they are not aware that these are the problems, or these are as a result of mental disorder. So they don't know whom to consult. So they take them to different faith healers instead of taking to mental health professionals. Scarcity of mental health professionals, financial constraints, lack of availability of medications, stigma and discrimination. So all of these act as barriers to take treatment. So 3 out of every 4 individuals is not receiving 3 out of every 4 individuals with schizophrenia is not receiving treatment. So in India, it's about 0.4%, but approximately in US and all, they say it's about 1% lifetime prevalence. That is 1 in 100. So schizophrenia occurs equally in both males and females. However, in males, the disease starts early. So they are at more risk of more dysfunction, and their prognosis is bad. So the age of onset is less than 25 years. This means that schizophrenia begins in late adolescence and early adulthood. So that is a peak time wherein one, academic achievements and also the routine competitive time. So in this world, like the educational and even job placements, all of these are affected when schizophrenia occurs at this productive age. Then prodrome. Prodrome means before the onset of schizophrenia also, there are certain symptoms which show that the person is slightly different from other individuals. For example, there are slightly less in social interactions, they are a little poor, or difficulty concentrating, and other lack of interest in activities. So some of these negative symptoms could be present in prodrome. So after years of this prodrome, one might develop schizophrenia, especially after there is some major stressor. Could be a death of family member, or it could also be any failure in an examination, job loss, or financial stress, etc. So because schizophrenia is occurring at a young productive age group, because it's a chronic and severe mental disorder, there is significant impairment in the life of the individual. In fact, not only the person, but the entire family also faces a lot of dysfunction. So there are multiple comorbidities with schizophrenia. So the person can have other psychiatric issues like mood symptoms, anxiety. There can be substance use. So usually cannabis, nicotine. So nicotine use will increase after after the person has schizophrenia, because by taking it there is some amount of reduction in the hallucinations. So these individuals tend to consume more nicotine. They're also at risk of multiple medical disorders like diabetes, hypertension, obesity, hyperlipidemia. So all of these are put together known as metabolic syndrome. These can directly be there in schizophrenia, and sometimes they're also adverse effect of some of the medications used to treat. So based on all these things, there is also a risk of premature death. Almost about 10 to 15 years, these individuals live 10 to 15 years less when compared to the general population. Another major reason for premature death is there is almost a 10% risk of suicide in individuals with schizophrenia. So the course of the illness, onset of the illness is variable. For some, it can suddenly begin. So out of the blue, one day they begin having hallucinations. That is called abrupt or acute onset of the illness. For some, it may be chronic, insidious, like they don't know when, they can't pinpoint this week or this month the person had illness. It is like over a period of time it has developed. So it's called insidious onset. So that has a bad prognosis. So course of the illness. So course can be continuous. This is a common thing wherein there is continuous course with mild fluctuation. Sometimes the person will worsen, sometimes they'll improve. So something of that sort. Next is episodic course. In this episodic, there is a symptoms for some period of time. Then they come to either normalcy or the symptoms reduce to some level. So some individuals, they'll just have one episode of psychotic symptoms, and then they completely remain normal for the rest of their life. So in that one episode, if you treat properly for that period of the episode and maintenance period for some months after that, they don't tend to have another episode. So they are leading normal life, right? Almost as very good life as any one of us. Then multiple episodes. So some people, when they don't take treatment, the risk of episodes will increase. And for some, even on treatment, they still tend to have multiple episodes. So after an episode of illness, there can be reduction of symptoms to a great extent, which is called partial remission, or there can be significant reduction or complete reduction of symptoms, which is called complete remission. So there can be multiple types. So each individual has a different course of schizophrenia. The symptoms are different. So substance use, which I had already discussed, nicotine, cannabis, alcohol. Cannabis-induced psychosis is one major problem. And alcohol also can cause delusions. So multiple substances, even the stimulants or the medicines like amphetamines can cause certain medication side effects also result in psychosis. So psychosis, in fact, yeah, this is one thing. People think that psychosis, schizophrenia, all of them are lot of different conditions. But in fact, schizophrenia is one part of the psychotic spectrum of disorders. Psychosis could be of many types, like something like only delusions could be like persistent delusional disorder. Meeting the specific symptoms could be schizophrenia. With mood symptoms, it's called schizoaffective disorder. So multiple subtypes. So prognostic factors. Prognosis means an estimate of how well the person will improve. So good prognostic factors means the factors which show that the individual is more likely to respond to your treatment and have a good outcome. So if the individual has late onset of schizophrenia, then already they must have achieved good academic and occupational functioning. So that won't impact them significantly. And if it's an acute onset, suddenly the symptoms have started, you treat them and then they improve nicely. Clear precipitating factors, like I earlier mentioned, a job loss or, failure in an exam, etc. Then good premorbid functioning. That is, before the disease occurred, if the person was functioning well, did not have more temperamental issues, personality issues, then they'll have a good prognosis. Married people and those who have good psychosocial support will have good prognosis. And if there is no family history of schizophrenia, but probably family history of mood disorders, then also good prognosis. Positive symptoms have good prognosis, whereas negative symptoms have a bad prognosis. So almost exactly opposite things. When they're there, it suggests that person has bad prognosis, like early onset, insidious thing, then without any apparent precipitating factor, poor premorbid functioning, single status, married, divorced, anybody who have poor psychosocial support. Okay, family history of schizophrenia, somebody who has multiple relapses, long duration of disorder, and no remission. All of these indicate bad prognosis. So the next is etiology, which is the cause of schizophrenia. Many individuals and families want to know what is the cause. Why did they develop this disease? Is it that they have done anything wrong and all? Like we had earlier discussed about some of the myths. So there is no single cause of schizophrenia. It is multifactorial. So major causes are genetic causes, then neurochemicals. Neurochemicals are the chemicals which are there in the brain, which are responsible for communicating between brain cells to send signals to one another to transmit the messages. Then there could be structural changes in your brain. Biopsychosocial model. That is, there are inherent biological vulnerability. That is, they could have some family history of psychiatric disorder, and psychological factors like low self-esteem, adverse childhood reactions, social stressors, like death of family members. So all of these put together precipitating or leading to the development of schizophrenia. Infectious causes. For example, it was more schizophrenia was more common in individuals who were born in winter. So that could be because of more viral infections, the common cold and all. So that influenza probably leading to schizophrenia. The obstetric complications, these are delayed birth cry. Okay, that is immediately after the baby is born. If they don't cry, there'll be brain brain damage will be there. Then birth before 9 months of gestation. So other problems during delivery as well as during pregnancy. Then social stressors and drugs, like already we have discussed, some substances like cannabis and all, or medications also. Then regarding genetics, so this may not be significantly important for the general public, but it can be useful more for the mental health and other healthcare professionals. So schizophrenia has a very strong hereditary component, because even if one twin is having schizophrenia, the other twin has 50% chance of getting it. And if one parent has, the chance of children getting schizophrenia is almost 10 to 15%. Whereas in general population, it is just about 0.5 to 1%. So it increases so many times. But if both the parents are affected, the risk goes up to almost 50%. That is, 1 in out of 2 to 3 children of these parents will have schizophrenia. And multiple copy number variants have been identified. Many genetic loci like DISC1, catecholomethyltransferase, neuregulin, so many others are identified as risk factors for schizophrenia. Even increased age of the father also is considered as risk factor because of accumulation of mutations in the sperm. Then there are 3 main theories: the dopamine theory, glutamate, and serotonin. So I said these are the neurotransmitters. So there is increased dopamine D2 activity in the mesolimbic system, or function, the hypoglutaminergic in the NMDA receptors, then increased serotonin in the cortex. So all of these could result in schizophrenia. And these are the dopamine pathways. So on your left, there are 4 pathways which have been mentioned, but I'll just focus on 2 main things which are implicated in schizophrenia. So first, you're able to say VTA, right? The black circle. That is ventral tegmental area in the midbrain. Then the limbic system. So the connection between VTA and limbic system is the mesolimbic pathway, which is wherein excess dopamine activity results in positive symptoms of schizophrenia, and reduced dopamine activity results in the negative symptoms of schizophrenia. Then the connection between VTA and the cortex, which is there in the top black area, is called mesocortical pathway. In mesocortical pathway, there are 2 areas. Like the cortex is divided into dorsolateral prefrontal cortex and ventromedial prefrontal cortex. If the dorsolateral one is affected, then there will be cognitive symptoms and negative symptoms. If the ventromedial prefrontal cortex is affected, like there is low dopamine, then you get negative symptoms of schizophrenia and also affective symptoms. Okay. So other neurotransmitters like excess serotonin causing both positive and negative symptoms. Then glutamate neurotoxicity. Norepinephrine is a hormone which, it's a neurotransmitter which is responsible for pleasure. So when that is, those neurons are dead, then the anhedonia will result. That is, you don't get any pleasure out of any activity. Then loss of GABA neurons in hippocampus, so which is involved in memory issues, including acetylcholine and nicotine. All of these are implicated in cognitive dysfunction. Then other etiologies, ventricular enlargement. Ventricles are fluid-filled spaces in the brain. So when they are enlarged, the other normal brain cells have reduced, especially in thalamus and all. The right and left hemispheres are not not symmetrical in these individuals. Then by using advanced techniques like magnetic resonance spectroscopy, it was found that there is reduced concentration of NAA, and there is abnormal eye movement also in individuals with schizophrenia. Some autoimmune theories also. Then cannabis-induced psychosis, perinatal insult I've already discussed. So this is one case vignette I want to discuss before going to the clinical features in detail. So try to imagine.
Ma'am, you are muted.
Okay, am I audible now?
Yes, ma'am.
Okay,
Yes.
so
Yes, ma'am.
he was brought by his wife with the following complaints. So for the last 15 years, he was muttering to self. He was talking as if somebody was there nearby him, gesturing and all, but there was nobody. So when family members were asking, he would tell that he would hear the voices of people scolding him. So these happened for the last 15 years, but family members did not pay much attention to it. But from the last 5 years, he was also very fearful that the entire world was trying to harm him. And he said that many people are trying to kill him. So he stopped going to his work. He was staying in house the entire day. So for the past 5 years, he's not working. So then family members were concerned and they took him to multiple faith healers. But nothing worked out. And the person was gradually worsening. So for the last 2 weeks, he was not taking care of himself. He was sleeping less. And 5 days back, he went away from home. And 2 days back, he was found on the street in torn clothes, and he was laughing loudly, inappropriately. And then family members had brought him to the psychiatrist. So I'll be discussing more about this case towards the end of the presentation. Okay. So clinical features, we had already discussed about these positive symptoms like delusion, hallucination, disorganized thinking and behavior. Negative symptoms, it could be affective flattening. That is called blunting of affect. So when you're normal individual, see if there's something, a joke is cracked, you laugh. If something sad happens in your life, something bad, then you feel sad. Whereas in these people, they don't have that emotional response to it, and reactivity is lost. So they appear like dull, sort of expressionless. So then avolition, wherein they don't have that internal motive to do something, apathy and anhedonia, lack of pleasure, alogia, not speaking much. Then asociality, do not want to interact with people. So all of these are negative symptoms. Then cognitive symptoms I've already discussed: reduced attention, concentration, memory, other problem solving and all. So Kurt Snyder, he had given these first rank symptoms of schizophrenia, which he said that auditory hallucinations, that is hearing voices, there are three types: first person, second person, third person. So first person is hearing one's own thoughts spoken aloud. So the person is not speaking, but he hears them. Then second person, running commentary. So just like a commentary in your cricket match, there will be voices which are saying, Acha, okay, Raju is sitting, Raju is standing, now he is walking, like that. Continuously throughout the day, voices will comment on the person's actions. Then there is third person. That is, these many voices are discussing amongst themselves about the patient. So these are the various types of auditory hallucinations. Then disorders of thought. So here the patient feels that his thoughts are not his own. Instead, somebody has planted them in his head. So that is called thought insertion. When he's speaking, suddenly he feels that somebody has taken away his thoughts. So that is thought withdrawal. Then thought broadcast is his own thoughts are being known to the entire world. That is how he feels. He gives them various possible explanations. They are diffusing through my brain, traveling through air or microwaves and all. So it's being known to everybody around, even though I don't speak. It's being broadcasted in television, social media, etc. Then made phenomenon. Made phenomenon refers to somebody is making me do this. That is, my body is not in my control. That is the meaning of made phenomenon. So made affect means my emotions are not under my control. Made volition, I mean the acts which I'm not doing, which I'm doing are done by somebody else. So that. Then somatic passivity. It refers to experience of sensations which are attributed to an external cause. So to put it in simple terms, I say that I'm having something pricking inside my stomach with needles, and somebody is sitting in an, say Europe is using radio waves to do that to me. So I'm a passive recipient of some other influence, external influence. Then delusional perception. This means that you are able to see something. Perception is normal, but I'm attaching a delusional meaning to it. So I see a message on my phone. Then I say that seeing the message is the correct one. So I'm perceiving it correctly, but I'm giving a delusional meaning. Okay, this message is kept by aliens to insert cancer in my head. So that is completely false notion. Okay, so nowadays we don't give that much importance to first rank symptoms. However, it's a good idea to know because you see these complaints in patients. Okay, so I'm giving a brief description of how a person might appear, because pay attention to this, because you need to identify these problems and then ask patients to seek treatment. So patients will be ill-kept sometimes. They don't make eye contact. They have abnormal movements, hallucinatory behavior. That is, I was saying, they speak in the air, make gestures, try to close ears to avoid hearing those non-existent voices, etc. There can be psychomotor agitation or retardation, pacing around the room, or completely sitting still, like in catatonia. Speech and thought disturbances and affect I'm going to discuss further. So thought, there are different form of thought, flow of thought, content, and possession. There are changes. So in flow, there could be flight of ideas. That is, from one topic to the other, the person is rapidly shifting. Then clang associations, that is rhyming associations. Poverty of speech, that is the content of the quality, the message conveyed by that speech is limited. Then form could be tangentiality, circumstantiality. Tangentiality will be like they start off giving a proper response to your answer, but they go away to some other topic. Then loosening of associations. Neologisms is framing new words which are not in common usage. Perseveration, using the same repetitive nature. So I might say, my name is Devika, my name is Devika, Devika, Devika. So that is perseveration. Then metonyms, using a new word which is used to, which also conveys a meaning, but it is quite odd. For example, instead of saying a glove, I might say it is a foot sock. So that is a metonym. Then content. So it could be overvalued ideas or delusion. I've already discussed about delusion, right? Overvalued ideas are also something which is held to firmly and which is sort of to an fixed extent, but it does not cause significant dysfunction. So in delusions, it could be persecution that others are trying to harm them. Referential delusion means that people are talking about me and all. Bizarre, something which is impossible. That is bizarre delusion. Other types, grandiose is more like I'm the best I'm the richest person on earth or something, wherein the self-esteem is very much inflated. Then possession, I've already described these in the first rank symptoms of schizophrenia. Then perceptual abnormalities, hallucinations which can be in any of the modalities. That first picture is wherein the person, the female is closing her ears because she is these voices are speaking to her. So those are auditory hallucinations. In the next picture, there's so many people that the person is seeing. So those are visual hallucinations. He's scared of those people. So then tactile hallucinations, olfactory, gustatory, visceral. So many types. And then there are other special types, which if you're interested, you can go and read up, like functional types, reflex hallucination, etc. So catatonia. So this is a state which has of late been reducing because we have good medications. In the past, many patients would present with catatonia. So if 3 out of these 12 symptoms are present, then you can diagnose as catatonia. I'll just tell very briefly. Stupor is significantly reduced level of consciousness. Catalepsy is you're able to induce a posture. For example, I'll push my hand like this. For example, I'm pushing a hand of patient up and the patient continues to keep it like this. They don't get back to normal position. That is called catalepsy. Then waxy flexibility is when I'm passively moving the hand of the patient, you get a mild, slow resistance throughout as if you're bending a candle. Then mutism is self-explanatory. That is, there is significantly reduced talk or completely they stop talking. Negativism is they either don't follow your command or they do exactly opposite. For example, if I say, show your tongue out, they may not obey it or they may in fact keep their tongue inside. So that is negativism. Posturing is they hold it in abnormal posture. It's similar to catalepsy, but in catalepsy, examiner is moving them to abnormal posture. In posturing, the person themselves keep an abnormal posture, for example, standing on one leg for hours together, etc. Then mannerism, stereotypy are repetitive movements itself. Mannerism, it's purposeful, it's odd movement, which is totally abnormal. Stereotypy could just be like, say, I'm touching my face multiple times. Repetitive is the issue. Agitation without any purpose. Then grimacing. Echolalia, repeating the same thing, words of examiner. Echopraxia is repeating the same actions of the examiner. Then finally coming to the impact of schizophrenia. So because schizophrenia strikes at a significantly important phase of the person's life, there will be reduced academic achievement, difficulties in obtaining jobs, so socio-occupational dysfunction, issues in marriage leading to divorce, chronic medical illnesses like I've mentioned, diabetes, hypertension, obesity. Then death by suicide is seen in 10% of these patients. Caregiver burden, that is, family members who are taking care of the persons with schizophrenia also face significant exhaustion and, which is considered as caregiver burden, and it has to be addressed to avoid the burnout. So I'll just tell about management in one slide itself, because the next speaker is going to discuss it in great detail. Okay. So psychoeducation is the main one thing which you must definitely focus on. So psychoeducation means telling the patient and family members in a clear manner which they understand that, okay, this is your disorder. These are the symptoms. That is, these are the signs and, which you can see in the patient. So if these things happen, you need to take treatment. Treatment will be for long term. You should come regularly to meet your mental health profession. So all of these are psychoeducation. Then antipsychotics are the medicines which are the mainstay of treatment, and you also have other medications. You have other therapy like ECT and all. Important thing, ensure compliance with medicines means they should take medicines in the correct dose for the correct duration which is being prescribed. Then regular monitoring. It could be how the symptoms are progressing, what are the side effects, what are their lab investigations, how is their general condition. There'll be so much which a psychiatrist will keep monitoring on a regular basis. So one should keep visiting them correctly, regular follow-ups. Then therapies, there are many therapies, family therapy, vocational rehabilitation, many for improving the quality of life. Then you need to address caregiver burden. So the first case vignette that we had discussed earlier, now I'm just going to highlight the reasons why I had presented it. So since this person developed illness 15 years back, that is when he was 20 years old. So his education, he could not pursue further studies. So he stopped it at 12th. Then when he was getting these muttering to self and hearing voices, it is auditory hallucination. Then he was appearing fearful for the past 5 years with that belief that others are trying to harm him, right? That is delusion of persecution. Then he stopped working. So there is significant dysfunction, occupational dysfunction. Then the progress in symptoms are increasing over time. In the last 2 weeks itself, his self-care deteriorated. So that deterioration of symptoms. Then he wandering away from home since 5 days, the being found in torn clothes and, laughing inappropriately. All of these are disorganized behavior. So slowly, if you look at the symptoms are changing over a period of time, new and new problems are adding up. And the important thing I want to highlight in this case is delayed treatment. He was initially taken to multiple faith healers. They didn't know that it is a psychiatric disorder, needs to be seen by mental health professionals. So that delayed treatment has led to poor prognosis. So now the person has too many, like all socio-occupational dysfunction. He'll have higher chance to develop treatment resistance, negative symptoms, and so on and so forth. So overall, his prognosis is bad. So giving you another case illustration, which is exactly opposite of the first one. So in this, Miss A is a 25-year-old lady. She's a graduate and she's employed in the IT sector. So she was brought to the psychiatrist with sudden change in behavior for the last 1 week. So she had irritability. She was saying that everybody is are talking about her. So she was having delusions of reference. Then she also reported hearing voices of people who were commenting about her activities throughout the day. That is running commentary type of auditory hallucination. So she was immediately brought to psychiatrist and she was started on antipsychotic olanzapine. And her symptoms had subsided completely in 2 weeks. Then she did not have any other episode of illness. It's already been 2 years since she's maintaining well. So this shows that early treatment, that is timely treatment, has led to good prognosis in this case. So this is the contrasting thing I want to show between these two cases. Delayed treatment leading to bad prognosis, early treatment leading to good prognosis. So to conclude, schizophrenia is a severe mental disorder of the brain, which is a chronic debilitating illness leading to significant socio-occupational dysfunction, leading to disturbance in the person's life as well as their entire families. Then it has multifactorial causation. In India, the lifetime prevalence is about 0.4% and the treatment gap is 75%. 1 in 4 individuals with schizophrenia only receive treatment. So it's characterized by delusions, hallucinations, disorganized speech, grossly disorganized motor or catatonic behavior, and negative symptoms. Early diagnosis and management leads to favorable outcome. We need to eradicate the stigma and reduce discrimination towards persons with schizophrenia and bust the myths about schizophrenia. And with this, I would like to end my presentation and I'll be happy to take up questions in the Q&A session. Thank you. Thank you.
Thank you, ma'am.
Ma'am, if you could kindly explain waxy flexibility.
Okay, so in catatonia, when one tries to move the, for example, limb, I'm trying to flex the limb of the patient. So I'll be met with some amount of mild resistance, which is the same throughout the movement. Okay, that resistance. So when you're bending a candle also, you have similar feel, that constant resistance to bending. Okay, suddenly it will give, suddenly it will break. So this is waxy flexibility.
Thank you, ma'am.
Ma'am, I have a question.
Yes, please.
Can schizophrenia be related to any type? It can be linked with OCD, having OCD.
Yes, it's a very good question. So, yes, we consider it as a schizo-obsessive spectrum. That is, though schizophrenia and OCD are two separate disorders, there is some amount of similarity. There is higher risk of having OCD also. So, similarly, we also have schizoaffective spectrum. That is, individuals with schizophrenia having a higher risk of developing mood disorders like bipolar affective disorder, etc. So, it's a very good question that you brought up.
Thank you so much.
Ma'am, I
You're
have a
welcome.
doubt.
Yes, please.
Ma'am, you told that in the session, so you said that sometimes without one particular incident can cause schizophrenia. Like,
Yes, yes.
can we say that there is some traumatic impact which can lead to nightmares and PTSD? Can be having some comorbid conditions of schizophrenic psychosis symptoms? Because there are chances that trauma also that can lead to some traumatic condition.
So, yeah, there are two aspects. So, early childhood, adverse childhood experiences, or any trauma for that matter, the psychological trauma can also sort of increase the vulnerability and also precipitate schizophrenia. Likewise, any physical trauma also, like head injury, that could also precipitate schizophrenia.
Thank you, ma'am.
Ma'am, I would also like to ask a question.
Yes, go on.
Ma'am, can you throw some light on childhood schizophrenia?
Okay, very good. So usual age of onset we said is in the late adolescence to early adulthood, right? So we also have childhood onset. We've seen it in children less than 10 years old, also somewhere right from 6 years or so. So they have similar symptoms, but they'll find it difficult to explain it. Children find it difficult to communicate about their problems. Also, initially, there was also a link suggested between childhood autism and schizophrenia because of that reduced social interaction and other, withdrawn behavior. So, yeah. Because in childhood onset schizophrenia, their academic performance is significantly impaired, especially if they are not diagnosed and treated early. It can lead to very bad prognosis.
And ma'am, are the symptoms similar to what we see in adults?
Yes, we have significant, some majority of symptoms are quite similar.
Thank you, ma'am.
Could you please, ma'am, could you please
I have one.
explain the dopamine pathway? Hello?
Yeah, please go on.
Yeah, ma'am, could you please explain, please explain again the etiology, the dopamine pathway, where you have 2 points where you explain the brain structure and the chemical secretion.
Yes, I'll go on to it. So basically, there are two major dopamine pathways which are implicated in schizophrenia. Okay, so one is the mesocortical, the other is the mesolimbic. So mesocortical pathway, there are in cortex two major parts: the dorsolateral prefrontal cortex and ventromedial prefrontal cortex. So when the dorsolateral prefrontal cortex is the dopamine transmission is reduced, then you'll have these cognitive symptoms, okay, and also negative symptoms, because that area of the brain is responsible for good cognitive functioning. Whereas if the ventromedial prefrontal cortex, if the dopamine transmission is affected, then you get negative symptoms and affective symptoms. Then the second pathway is the mesolimbic pathway, wherein excess of dopamine will cause positive symptoms like hallucinations, delusions, whereas reduced dopamine in these pathway will cause negative symptoms. Because limbic system is basically connected to emotions. So reduced emotional reactivity causing that blunting of affect, anhedonia, asociality, all of these are negative symptoms which are caused due to deficit of the dopamine transmission in the mesolimbic pathway.
Thank you.
Ma'am,
Ma'am?
I have one doubt.
Ma'am, I have one.
Yes.
Is there any suicidal tendencies in this condition, ma'am? If
Yes.
so, how can we identify?
Okay. So basically, especially in untreated individuals, the risk of suicide is very high. In fact, almost 10% of the patients end their lives by suicide. So treatment is very essential, and there is no single predictor. Like this shows that the person is going to commit suicide. So you just can't pinpoint to any particular thing. So one way you can try to reduce the risk is by providing adequate treatment.
Ma'am, I have one doubt.
Thank you, ma'am.
Ma'am, you talked about hallucination, auditory hallucinations, and in the hallucinations, you said that people hear their own thoughts. So how is
Yes.
that sort of different from thought echo?
Yeah, it is. Thought echo is also on the similar lines. There's not much of a difference in that first person auditory hallucination.
Thank you.
Ma'am, hearing affected people related to schizophrenia disease.
No, I'm sorry, I didn't get your question.
Hearing affected people related to schizophrenia disease.
Yes, they can also develop. It's a very good point that you raised. In fact, in individuals, elderly people with visual impairment, then hearing impairment, they also have these visual hallucinations, auditory hallucinations. It's a good point that you raised. Thank you.
Thank you, ma'am.
Hello, ma'am.
Yes.
हाँ, गुड आफ्टरनून मैम। मैम, मेरा वन क्वेश्चन है, अगर सिजोफ्रेनिया का कोई पेशेंट है हमारी फैमिली में, जैसे कोई भी है, तो हम उसको किस टेक्निक से उसको ठीक कर सकते हैं? जैसे कि जो प्रेस्क्राइब्स मेडिसिन है या अदर कोई काउंसलिंग सेशन है, तो उसके लिए क्या ट्रीटमेंट क्या होना चाहिए कि उसको जो हम ट्रीटमेंट दे रहे हैं वो उसको अर्ली स्टिमुलेशन में उसको कुछ बेनिफिट हो मैम?
Okay, so treatment I didn't discuss in detail because the next speaker is going to discuss about it, over the next 45 minutes. So I think I'll just give you a brief answer. Medicines are the mainstay of management. Of course, you also need to provide holistic management, giving adequate psychosocial support, the psychotherapies. So family support is also very crucial to get a good response to treatment and improve the quality of life of persons with schizophrenia.
Oh, thank you, ma'am. Thank you.
You're welcome.
Ma'am, I have a question. Ma'am, can auditory processing disorder or sensory processing disorder, person having sensory issues can lead to schizophrenia?
Yes, that was one thing which we had discussed. They can also have auditory hallucinations. So, like psychosis is seen both in individuals who have visual impairments, auditory impairments. So, that's possible in hearing.
Devika, we are running out of time. Okay, no?
Okay,
Any questions you can send through email. Okay, no? I mean, the next speaker is waiting. And thank you, Devika, for your wonderful, brief, and simple presentation. And based on the mixed audience, like parents, teachers, professionals, you have given a very good presentation, which is simple, brief, and enlightening to everyone. And thanks for your time and for coming here. Thank you very much.
Thank you so much, Ravan sir, for giving this opportunity and to
Thank you so much,
the
ma'am.
entire team. Thank you.
Thank you, ma'am.
Thank you, ma'am.
Thank you. Welcome.
So now we are going to our
Okay.
second speaker. And I request all the CRE participants to fill the evaluation sheet and send it by email. Okay, no? All the CRE participants who are attending online, please send the evaluation sheet. You are having some questions, okay, now related to Devika Madam topic. You are having some questions. Please fill it and send by email. Okay, you are having the Google link. Submit. Okay, online you can submit. And now I invite for today's talk our second speaker on management of schizophrenia. And he is Dr. Nitin. He is a very young and dynamic speaker. And regarding a brief introduction of Dr. Nitin, Dr. Nitin has completed his MBBS from Mysore Medical College in 2011. He was acknowledged the best outgoing student award during his graduation. In between 2013 and 2015, he has done his diploma in psychiatry in Asia's largest psychiatry institute, NIMHANS, Bangalore. After finishing his course, he continued to work as a junior resident in the psychiatry rehabilitation services for 1 year. And also he worked as senior research fellow in a project funded by Canada Institute of Health Research in NIMHANS. And later he proceeded to Harvard University in Boston, USA in 2017 to do his master's in neuropsychiatry epidemiology. He was the first psychiatrist to achieve his degree, master's in neuropsychiatry epidemiology. He also worked briefly in Harvard Medical School as a research assistant. After completing his master's, he began working as a research analyst at the Harvard India Research Center in Bombay for 1 year in 2018. He is working in Hyderabad as a consultant psychiatrist at Aster Prime Hospitals in Hyderabad since 2019. In addition to serving as a psychiatrist, he is also a freelance mental health consultant for many startups such as Lakazoo and Marriage Fit. He has a vast variety of job experience of more than a decade experience, and he has worked in multiple urban cities like Bangalore, Mumbai, Thrissur, Lakshadweep, and Maldives. So I welcome our next speaker, Dr. Nitin Kondapuram. Nitin, handing over to you.
Thank you very much for the introduction, sir. Thank you, Devika, for giving a brief about what is schizophrenia and how things are going about. I will talk about more about the management. Let me present the screen. Yeah, so you all can see my screen. Is my screen visible?
Yes, sir.
Yeah. So coming to the management of schizophrenia, as Devika has said that it all starts, it has a multimodal factors like why the schizophrenia happens. And it all goes on from the childhood, early adulthood and adulthood. It can go till the death of the patient. So why managing schizophrenia matters.
Dr. Nitin, sorry to interrupt. Make it full screen, no? Your presentation.
Yeah, it's full screen, sir.
But put it on slideshow, okay? No? Put it on slideshow.
It's on slideshow only, sir. It's not coming?
No.
No, sir?
No, Nitin. Nitin, press F5, okay? Press F5.
Yeah. No?
Okay, it's okay. You can continue, but it's not coming full screen. Okay.
It's coming now, sir? Is it full screen now?
No, Nitin, no, we cannot see.
Okay.
You can try F5. You can press F5 and see once. And once again, you share, okay? You stop sharing.
It's coming now, sir.
Sir, may I interrupt?
Yeah.
Okay, so sir, I'll just explain it to you how you can do it. So can you see the raise my hand option in the Google Meet?
Yeah. Can you see it now?
It's not visible, sir. So you can share your entire screen first and then
Yeah.
open the PPT.
Yeah, understood. Yeah. But now it's better.
So your screen is not visible right now.
Your screen is not visible. One second.
Now? Is it visible now?
Yeah, now it's visible, Nitin. You can start your presentation.
Yeah. So why the management of schizophrenia matters? Like why does it matters? The reason is because like it comes as the uh, ninth most disorder in which the disability is very high. The disability assisted life years which are lost due to disability is pretty high compared to other non-communicable diseases. So that is the reason why schizophrenia matters. And also here, when we treat a patient with schizophrenia, we are not treating the patient himself. We are treating the whole family. It's not only a single person. So that is the reason why it matters. Now, coming to the management of the schizophrenia, the first thing is you have to establish the diagnosis. You have to be very clear that yes, this schizophrenia, this is not something else. It's not bipolar or this is not something else. And we should be very clear about it and we should have a target because each patient is unique. Some person might be obese like me, some person might be lean, some person might have too much of negative symptoms. So we need to find what the targets of each and every patient is. And then we have to develop a therapeutic alliance with the patient and also identify what the patient's goals are. If the patient is like, I just need my delusions to go up, I just need my hallucinations to go up. Some patients will be like, I need to go back to my work as I was doing like before. I want to be a good mother, I want to be a good father. So we need to understand what the patient goals and aspirations are. So the management usually involves providing the family with the proper information. What is illness? What are the early signs of relapse? Coping strategies. If the patient has any comorbid conditions.
So you're on mute. Sir, mute, sir.
Sorry. You can see. Can you hear me?
Yes, sir. So the previous slide of this, previous slide.
Okay, just a minute. You can hear me and see the slides?
Yes, sir.
Yeah. So what I was telling was like, we need to understand that each patient is unique. We need to identify what the targets are, and we have to identify what the patient wants. Some might require, say, like, I just need to reduce my delusions. Some might just say, I need to reduce my hallucinations. Some say that I need to go back to my work. I have to take care of my kids. So we need to understand what it is. And we have to, when it comes to the management of a patient, especially in mental health, it's not only the psychiatrist who is doing the work. It's a teamwork. The psychologist has to be there, the social work has to be there, the nursing, the special educators, everybody comes into the play. So we need to integrate as a team and go ahead and help the patient to come out of the schizophrenia or any other mental health illnesses. So coming to the treatment, there are three parts in schizophrenia. The major part, what everybody tells, is the pharmacology. But the two main important as a practicing psychiatrist is psychosocial and rehabilitation. They are the things which define how the progress of the schizophrenia go ahead. So coming to the treatment part in a different way, we can divide the schizophrenia into three things: acute phase, stabilization phase, and a stable phase. So what is the acute phase? As Dr. Devika just said, acute phase is the one which the patient has an onset of illness, is like disabled, he's not able to help anyone, he's creating a lot of problems to others, and he's brought to the hospital. So what the acute phase done? Our goal during acute phase is to reduce the risk for the patient and for the others. And we have to see that his disturbed behavior has been controlled, the hallucinations, the delusions, whatever he has been controlled. This can stay from when we start giving the treatment, it can stay from 2 weeks to 6 months. So it all depends upon how the patient responds to the medications. Along with this, we have to formulate both a short-term goal and a long-term goal. Say the short-term goal is to reduce his symptoms. The long-term goal is to relocate into the society, into the community, or to get back to his work. In acute phase, we have to do the assessments. So we have, the first and foremost thing during the acute phase is to assess why the patient got schizophrenia. Everybody will talk about the stress module. So what was the reason? Was it a bad marriage? There were a lot of stress going on? Was it a financial stressor? Was it a personal stressor? What was the reason for it? Because if we find that the reason, once we treat the patient, we can prevent him from having the same thing again. We can work on this and we can stop. And also we need to assess, is there any risk of suicide? Because we also know that the percentage of people who commit suicide in schizophrenia is pretty high because of the auditory hallucinations and any risk of violence. Many people, they get violent because they feel that the other people are talking about them. They can go on to the market, they can just beat them up. So we need to assess whether the patient needs an outpatient care or an inpatient care. And then we have to, as I said, once we understand what the stressors are, we need to reduce those stressful environment. Say if the patient is there in the home where there's a domestic abuse going on and that has led to the schizophrenia, we move her out of that kind of stressful situations and then provide information what exactly is going on with him and what will help him out. And then start using the antipsychotic medications. So coming to the medication wise, the pharmacology part, there are many antipsychotics available. We usually divide them as typical antipsychotics and atypical antipsychotics. Typical are old generation or the first generation antipsychotics, and atypical are the newer, which are also called as the second generation antipsychotics. And choosing which antipsychotics, it all depends upon the individual. One person might do pretty well on a particular medication. Other person can, with the same dose, can get a lot of side effects. So it is unique. It's all trial and error basis. But there are many antipsychotics which we use, which have minimal side effects, and it also helps to reduce the auditory hallucinations and reduce the hallucinations and the delusions. So, as I said, patients' preferences should be taken. Past response of the medications. If the patient had already taken the medication in the past for some time, that if that helped, we can use that. If the patient's parents or anybody in a close relative had schizophrenia and they had taken a particular drug, say risperidone, and it had worked, so there are chances that the same thing can work in the patient because it's all in the genes and the side effect profile of the medications. The second generation antipsychotics, which I said, can cause diabetes and a lot of other metabolic syndromes. So we have to be, say, if a patient who is in his 50s, who has already had a lot of, say, high cholesterol and had few heart attacks and all, we can't give them a second generation antipsychotics. We have to be very careful about that. So it all depends upon what comorbid conditions they are in. As I said, like research-wise, there are plenty of evidence available that medications do work in reducing the first-line symptoms of the patient in a schizophrenia. And there is no comparison between the first generation and the second generation. Most of them are effective. It all depends upon person to person. As I said, there's very little evidence between the first generation and the second generation when it comes to how they work and what's the quality of life after the treatment. And even in second generation antipsychotics, there are almost 34 to 50 second generation antipsychotics available in the market, there is no molecule which we can say that one is good and one is bad. Everything is good. It all depends upon how the patient perceives, how his body takes in, and whatever the side effect profile it comes in. So this is a list of the medications. These are all the first generation antipsychotics. This is the chlorpromazine was the first antipsychotic which was found, and then later on a lot of other antipsychotics came in. So these ruled the medication part till the late 1990s or early 1990s or the late 1980s. If you all have seen a movie called Shutter Island, you can see that the hero keeps on smoking. The reason because the cigarette which was given to the patients here, it's full of chlorpromazine. So it's also said, and that's how we can see that this movie is based on in 1980s, and that's how it's the movie runs in an asylum where the patients are given the medication, they don't take it. So what they did is they made it into cigarettes and they start giving it to the patients. So these are the various first generation antipsychotics which are available. And the main important thing what we have to see is there are two medications which are available in an oral solution forms. Coming to the second generation antipsychotics, they are all newer antipsychotics which were usually discovered after 1990s or 2000s, and they are available in various forms. They are available in tablets, injections, solutions, or also as rapidly dissolving, because we know that few of the patients might spit out the tablets. In them, we use the rapidly dissolving tablets so that the moment they take the tablet in their mouth, it melts down. It melts down and they will not have any kind of difficulty. They will not have the possibility of throwing them out. The other thing, one more important thing is, there are few medicines which are available in oral solutions, the use of which I will tell you a bit later. And the initial doses, it all depends upon the body weight. So we usually use risperidone, olanzapine, or other medications. Risperidone is from 2 to 8, olanzapine is 10 to 20, 5 to 10. We can also use quetiapine. We start with 50 mg, we can go up to 300 or 400. So it all depends upon the patient's symptoms, his body profile, and how much the medication he needs, and also the side effect profile. So here is a kind of a summary of how we choose the medications. Say if it is the first generation, we go with the newer generation antipsychotics. We'll see if there is having any kind of side effects, then we switch over to something else. And even if after using two newer antipsychotics, the patient is not responding, then we go with something we call as clozapine. Clozapine is something which we use in treatment-resistant schizophrenia. And also, if there are some patients who are not willing to take the medications. They are like, "Mujhe nahi chahiye, main nahi khaungi, mujhe kuch bhi, I don't have any problem. I'm perfectly well. You are just making up things." In them, what we use is a long-acting injectables. These are nothing but the medications in a depot form, which are given once in a month or once in 15 days. Usme a little bit of medications will be released on a time basis every day, so that it is equivalent to what the patient was taking orally. So this is usually the choice of the medications. Since there are a lot of people who are from a non-medical background, I would like to focus more on the other treatment parts. And in acute phase, we also use a lot of benzodiazepines, or also known as sleeping tablets. It is to make the patient calm and to have a proper sleep, because if a person sleeps well, there are very high chances that the next day the symptoms can reduce.
सर आपको पीपीटी नहीं देख रहा है सर आपको पीपीटी नहीं देख रहा है
Not visible, sir. PPT not visible?
पीपीटी सर not visible sir.
You can see now.
It's visible.
You can see
and audible also. Yeah, you're audible also, sir.
Yeah, so I'll just keep it like this.
Screen not visible.
You can see now.
It's visible.
It's visible, sir.
दिख रही है सर.
Shall I continue?
Yes, sir.
Not visible.
Sir, PPT are not available. PPT is not visible, sir.
Yes, yes, sir. Only yours audible. But
इंटरनेट का प्रॉब्लम होगा आपका. दिख रही है.
PPT not visible, sir.
Sir, PPT not
Yeah.
visible.
You can see the PPT?
Yes, no, sir. We
No,
can't
it's
see the
not
PPT.
visible now.
No sir.
now not visible, sir.
Now?
Now it
No, sir. Visible, sir.
Yeah, it's visible, sir. You're presenting. Yeah, it's visible.
Yeah. So in the acute phase, so as I said, so this is the choice of the medications. So as I said, in the acute phase, we give the treatment. We also give a little bit of sleeping tablets so that sometimes the patient might not feel sleepy and he may not get sleep because of the hallucinations and the delusions. So we give a little bit of sleeping tablets so that he can happily sleep, he or she can happily sleep. And sometimes having a good sleep can reduce the amount of symptoms which you have the next day. And the other important aspect is the ECTs. ECTs are the electroconvulsive therapy which we give in patients with higher amount of symptoms, say like higher amount of symptoms, or if they have risk for themselves, or if they have risk for others, if they have those suicidal ideations, or if they have those catatonia kind of a features. What we give is an electroconvulsive therapy, which is nothing but we send a little bit of electric current through the brain using a machine which is very safe. We give it a very mild amount of current so that it goes into the brain and it induces seizures or fits. The reason why ECT came in was it was found in the past that the patients who have fits or epilepsy, they never used to have any kind of psychiatric disorder. So that's how the ECTs came in, and ECTs is one of the safest modality. It is not how it is shown in the movies, heart pair bhandia, or you give the current. It's we give them a little bit of anesthesia, a short anesthesia. We give them a brief electric pulse, and then the patient has a seizure or a fits. At the time, there are 4 or 5 people who are helping the patient. And after that, after 5 or 10 minutes, the patient can happily walk back to the ward. It is not as deadly as it is shown in the TVs. And I'll say that ECTs are so effective that if you ask a psychiatrist and a pregnant lady comes in, say 6th month or 7th month pregnant lady comes in, and if she has the symptoms of schizophrenia or depression, we prefer to give an ECT because it is the safest modality compared to medications. Medications might have some side effects on the baby inside, but we prefer to give ECTs because it doesn't have any kind of side effects other than a mild headache. Okay, so the other things what we have to focus in an acute phase is the poor prognostic factors. If the patient is a male or already was having untreated schizophrenia for more than 5 or 6 years, or if he has more of a negative symptoms. So these all are poor prognostic factors. We have to keep this in mind when we psychoeducate the patient and we psychoeducate the family members. So we come to the next phase. So we treated the patient in acute phase. Now the patient symptoms have come down. So now we will go to the stabilization phase. Stabilization phase is usually for 6 months from the start of the symptoms. It is to minimize the stress and provide the support to the patient so that the symptoms doesn't increase. It can be done with the medications, but there are a lot of other factors which also needs to be done, which I will tell you in a few minutes. We have to see, as I said, give the medication for 6 months and give the supportive psychotherapeutic interventions to the patient, be it supportive psychotherapy or be it family interventions, be it working on the expressed emotions, all these things which I will discuss in few minutes. And the last one is a stable phase, which is after the 6 months of the start of the treatment. In this, the goal is to bring back the patient to the normalcy. Where if he was working well, make him back go to the work. If he is a household who is to cook and do everything, take care of the whole family, make her do that. So that is the main intention of the stable phase. We have to maintain her symptoms so that she doesn't deteriorate, and also make her fully functional so that she can reintegrate with the community. So here, the psychosocial treatment matters. This includes the cognitive behavioral therapy, the family interventions, supported employment, social skills training, assertive community treatment, assertive community treatment. Uh, as I said, antipsychotics can reduce the risk of relapse, but there are a lot of other things which we need to take care of. The other thing is adherence. Some patients feel that if they take medication for some time, the hallucinations and the delusions come down. They feel that they're completely ill and they stop the medications, and the symptoms they come back. Because as we know, as Devika said, schizophrenia can be a continuous kind of an illness. So we have to make sure that the patient adheres to the medications. The reason why the patient stops is lack of insight. He doesn't feel that, okay, I am pretty good now, I need not take medications. It can be because the side effects of the medication. It can be because of the in schizophrenia, there are memory deficits that can lead to the patient may feel that it is because of the medications I'm losing my memory and he can stop the medications. It can be because of financial concerns, because like if they are going to a corporate hospital, they're spending a lot of money, they are not getting medications there. So there are a lot of factors in which the patient may not adhere to the medications. But as I said, 50%, like it's important for the patient to take the medications for some time till the patient comes into the stable phase. Coming to the psychosocial treatments, the most important of all this is a cognitive behavioral therapy, followed by psychoeducation and family therapy. And then comes the rehabilitation. It can be social skills training, vocational rehabilitation, or sheltered employment, and a lot of other things. Coming to the cognitive behavioral therapy, so when we take back to the history, we all know Beck, he initially started to do the cognitive behavioral and psychosis. What he observed was that he did it on a patient with 7 years history of schizophrenia. There, the patient was able to learn to reason himself with the beliefs which he had. He was having hallucinations, and he started to observe that, okay, these hallucinations are nothing but my own inner thoughts, which I should not give importance to. So that's how the CBT started. And what the initially before till 1990, what the CBT was about to eliminate the various behaviors they have. So if the patient is having hallucinations, stop talking to them or ignoring those kind of thoughts. If they feel that somebody is coming to kill them, to ignore those kind of thoughts. But after 1990, these things have changed. Now, since the side effects of the medication started to increase, the psychiatrists and the psychologists felt that, okay, there is a need for CBT to come in and help the patient to do much, much better. So that's when the stress diathesis model came in, or the stress vulnerability model. The stress vulnerability model, it says that a patient becomes vulnerable because of life events or use of substances or due to some adverse environments. Say, for example, like he moves suddenly from Hyderabad to suddenly moves to Canada, where it is completely dark and snowing all the time. So it can lead to some kind of a mental illness. So that's when this stress vulnerability model came into the fact. So this is how the model works. So the patient, we are all vulnerable. We say the patient has a genetic load. His coping mechanisms are bad, and he also has a lot of family history. Then the life stress comes in, some kind of a trauma, some kind of a drug abuse comes in. If he has good coping skills, strong social networks, regular medications, he doesn't have any kind of an illness. But if he has maladaptive coping, drug abuse, or interpersonal conflicts, that's when the risk of developing psychotic illness increases. So the protective factors reduce and the risk factor increases. So this is what the stress vulnerability model tells us. So when we put this into the fact, into how we can explain this in schizophrenia, so there will be a trigger. There's an emotional changes. Say a person got sexual abuse, that leads to lot of thoughts. They start to believe that they are fit for nothing. they started to feel the external, they feel that the abuser they can hear the abuser, or they can feel that the abuser can kill them off. And all these things can be added up. Say like they stop going out of the house. Somebody, like when they see outside, they start smiling at them. So that means that the patient might feel that okay, they are trying to look at me, they're trying to harm me again. So that's how all these things lead to, over a span of time, can lead to these kind of positive symptoms. So how we can explain the delusions is it can occur in a continuum, or it can be jumping to a conclusion. In the example I said, if the patient goes out and some of her friends start to talk to her, she might feel that okay, these people are judging. These people are here to get some more information and give it to the abuser or something like that. And because of all these things, they start to overthink a lot, and that leads to increase in the dopamine production in the brain. And also due to defects in the self-monitoring system. And when they feel that kind of a panic, what we usually do is we usually shut down ourselves and go back inside. But here the patient starts to interrogate more. Why you have come here? Why you want the details? Why, etc., etc. So they go on interrogating things. So the self-monitoring thing goes off. So that's how the delusions start to increase. And when it comes to hallucinations, it can be due to random firing in the speech processing mechanism. So we all know there are auditory zones in the brain, the Broca's area and the Wernicke's area. There is an increase in the firing of the neurons in those areas. And there's a faulty internal monitoring of the speech, and also some kind of a belief. They feel that, okay, somebody is screaming at me, somebody is talking to me. And whenever they feel that there is increase in the dopamine release in these speech areas, that leads to the hallucinations of the patients. And when we come to the formulation of a delusion, we can say, when we talk to the patient, we can say that on what evidence the patient's thoughts are based upon. Like as a therapist, you can ask the questions. How do the paranoid thoughts build on the patient ideas? How do the thoughts make sense even to the patient? Is the person reacting to the person or the confusing experiences? How is the person reasoning about their own experiences, and what behaviors are they keeping up? So all these things, as when we talk to the patient, we can formalize these delusions so that it can help in the cognitive behavioral therapy. Now, not all patients might be suitable for CBT. For CBT, the patient should be willing. The patient should have a good cognition. He should not have any kind of memory loss. He should be say that yes, I have delusions, I have hallucinations, I accept that I have schizophrenia. And there will not be any kind of formal thought disorder, which Dr. Divya just explained. There should not be any kind of distress. Like the patient is keeping on crying because somebody is trying to harm her, we can't do a CBT. We need somebody with a stable emotions so that we can do the CBT. Now, the goals of the therapy are simple. We gave the medications, the patient is stable, but now what next? We can't some patients might stop the medications on their own. So what we have to do is we have to see that we can use the CBT to reduce some amount of symptoms, or we can reduce the amount of distress what the patient has, or enhance the coping skills and make them more functional so that they can go back and do the work. General format of CBT is it varies from 20 to 50 sessions. We all know it's between 30 to 45 minutes. And see that it's once a week. If it is twice a week, it will be a little more pressure to the patient. And duration is usually between, I would say, like 3 to 6 months or 3 to 8 months. The general approach will be first to make a therapeutic alliance with the patient and asking them to develop an alternative explanation for the symptoms. Somebody is trying to harm me. What is your alternative thing? Like, you do have any money with you? No. Then why are they trying to harm you? So find an alternative explanation from them. Reducing the impact of the positive symptoms. Now, because they are trying to harm me, the patient says that I don't want to go and meet with the people. So tell them, okay, why don't we go and ask them and try to interrogate with them? So when you start to reduce the impact of those kind of positive symptoms, a little bit of the patient will feel a little bit of confidence that, okay, this is not something which I think is. And then relationship to the medical medicine anyhow he is taking. So if you can do the first 3 steps with the medication, that's how the general approach of therapy goes in a patient with schizophrenia. As I said, assessment for CBT, get the diagnostic assessment and assess where the patient is going wrong. Is it his thought process or is it sensory process or is it's generally what kind of a feedback the patient is getting. So make sure that when you start doing CBT, what is your goal is at? What part of the thought process are you trying to make it? What type of cognitive distortions are they having? What kind of an say, defense mechanisms they are having? So have those kind of an assessments with you, which will help you out. So coming to the stages, basically first is developing a therapeutic alliances and then starting an alternate explanation in the impact of the positive and the negative. So here the techniques, what I have done is like asking the questions about the delusions, reality testing, like going and asking the people like, do you really want to feel it? Do you want to feel that okay, what's happening with you? And then normalization for hallucinations, having a voice therapy and other behavioral techniques. And finally, relationship with the medical manager. And coming to the engagement in the therapy, not all patients may be willing to be in the therapy for so long. After a few minutes, after few sessions, they may feel that okay, this is not working because we all know it's a slow process. It doesn't happen within just few minutes or within just 1 week. It's a slow process. So we need to engage them in the therapy, develop the empathy, respect and also tell them that I understand your issues, but we can solve it slowly together. Once you start doing that, that kind of catastrophizing thoughts which the patient has, that reduces and slowly they will start to feel better, and with the medications and the therapy, the improvement can go up to 90%. So coming to the cognitive view, as we all know the ABC, activating agent, beliefs and consequences, how we can do it in for a delusion. Okay, how we can do it in a delusion. Say here in ABC model, as I had shown, A is an activating agent, B is the belief, and the C is the consequence, which we all usually follow in a cognitive way. In a delusion, what we do is we have an antecedent, the doctor walks past the window, he did not see me. What is the belief? What he interprets? He thinks he's better than me and he is letting me know that he's showing off to me. So what is the consequence? The patient feels that, okay, the doctor is very big, I am very poor fellow, I am not, and he can move away from there. So this is the ABT model of the delusion which the patient has. So what we have to do is we have to challenge those delusions. We have to conceptualize the delusions as an interference, not as a facts. We have to elicit the interference change, and we have to challenge the inconsistency and the irrationality what the patient has. Okay, and then we have to modify those kind of cognitive errors which the patient has. We can say that the doctor was busy just walking by, or by mistake you saw the doctor walking past. So once we start telling that, we are challenging the thoughts what the patient is having. Once we challenge those thoughts, there are very high chances that with the medications working and the thought process can change. That can lead to a faster relief of the symptoms. Coming with the hallucinations, the same ABC technique. Say he hears a voice. Say somebody says that be careful, somebody is looking at you. And the meaning, it's a devil, he's watching, he's waiting you to kill you. And what the patient feels, he becomes panicked. He starts to move around, he goes inside and he locks his door. So what we can do in such kind of a patients, we can try to give some kind of a distraction strategies. Having an having an earphone with music which the patient can sing, which he knows the lyrics, or keeping some kind of earplugs in him, or some kind of an humming, or asking the patient to keep on humming some of the other voice, or some kind of a physical activity, some kind of a mind diverting activities, Also, focusing strategies. What I usually suggest for the patients is to start doing crosswords or do Sudokus, because that's when all your focus is on and you can start ignoring the voices. I have a patient who got complete all the positive symptoms went off. She's 42-year-old. She started to have schizophrenia at the age of 26 after the birth of her first child. All her symptoms went off by age of 30 except for auditory hallucinations. Even now, she has the auditory hallucinations, but with a lot of distraction techniques and a lot of CBTs, what we had with our therapists, now what the patient says is, हाँ, there are voices. हाँ, voices आते हैं, वो अपने आप बात करते रहते हैं. मैं अपने आप खुद का काम मैं करते रहती हूँ. I will do the work with my children. I do the homework for them. The voices, they all come on keeping and they all going, and I'm not bothered about them. So that's how the CBT can help in reducing the last 10-20% of the symptoms. And as I said, some kind of a cognitive strategies and some kind of an exercises like patient verbalizing or distracting. What are the, if they listen some kind of a voices, talking opposite to that, verbalizing their inner feelings can also reduce the amount of hallucinations. We'll go this. And yes, you have to be very cautious with some patients when you're doing a CBT. Not all distressing psychosis arise from the positive symptoms. There might be a lot of negative symptoms which might be under the carpet. So we have to be very careful about it. Focus purely on delusions and hallucinations as a source of distress. We should not worry about anything else in CBT. And other source of distress include, if the patient has PTSD, you do a CBT, there are higher chances that the PTSD might increase. So our focus is reducing the distress, not reducing the symptoms. So what are the good predictors of outcome in schizophrenia? Is the shorter the duration of illness, the better the prognosis. If the symptoms are less, the prognosis is good. If there are many good positive symptoms or the prognosis is good. If the negative symptoms are there, the patient may have a prolonged schizophrenia. Or if the patient has heavy phrenic kind of a schizophrenia, the prognosis is usually very bad. So all these things you have to keep in the mind. What are the patient, at what age he has come, what has led to the problem, what symptoms he has, what the current situation is, what is the family background, how much support system they has. So whenever you're seeing a patient with schizophrenia, all these things should automatically come to your mind, because when you're giving the medications or when you're giving the CBT, you have to keep all these things in your mind. Because if any one or two of these things go here and there, then it will impact the overall outcome of the patient. Okay. So as I said, the cognitive model, it also changing where the negative schemas are into a positive schemas. Coming to the negative schizophrenia, usually the patients will have a negative view of themselves or the negative view of others. They have the alogia, anhedonia, and a lot of affective flattening. They don't want any kind of pleasures. They don't want any kind of success, or they don't want any kind of resources. So these things happen in a negative symptoms. In cognitive model, what we do is negative attitude towards social affiliations attached to them. What we have to do is we have to try to substantiate that. We have to tell that, okay, you're feeling you don't want to work, fine. What is making you not to do work? The patient might say that I don't know. Then try to motivate him. Try to understand what is going in his mind. I don't want to work because he doesn't have a reason. Give him a proper reason. Probably you might have schizophrenia that's pulling you down. So why don't you start doing small things? So once you start doing small things, they don't want to go out. Ask them to go out and get some milk packet or newspaper. So slowly, if you do that, there are high chances that they start, along with the medications, they start to work on that. And again, with the ABC model, we can definitely try to reduce the amount of negative symptoms what the patient has. And coming to the other psychosocial treatments, educating the family members, formally, systematically giving them the answers, giving them the answers to their questions, giving them the proper information, what schizophrenia is, how long it will be, and how important are the medicines. Important. And this can go up to, we can say that psychoeducation can happen over half an hour. No, there are some patients who need, say, if the patient has a very high expressed emotions, negative expressed emotions, you might require at least 12 sessions of psychoeducation sessions. So it is not easy, but we have to put into the patient's mind and the caregiver's mind that the patient has and he needs a lot of support, not only with the medications, but also as a psychosocial support, what they require. Okay. And so the psychoeducation, the key things which should include is the diagnosis, the symptoms of the patient, positive and negative, psychosocial interventions, what is their coping mechanism, what is the crisis plan, what is the early warning signs, and if they have any kind of a suicide or relapse prevention. So all these things should be there when you are educating the family members about the patient. And there's a very good evidence that if you educate the patients, patient caregivers, there are very high chances that the amount of symptoms or amount of support what the patient caregivers give to the patient is very high. So psychoeducation is also very, very important. And then comes the social skills training. We usually see that schizophrenia reduces the cognitive ability of a person. So we have seen that there is a Malayalam movie. There are a lot of movies in which we see that patient is pretty good. Suddenly he gets schizophrenia, he loses everything, he loses his job, he starts to get on road like just like Tere Naam. In Tere Naam, the Salman Khan gets like he was very popular in the college and all, and suddenly he has to go into the mental asylum. So if you want to bring him out of the asylum, then that's where the social skills training comes in. So what the social skills training comes in, it has a lot of sessions which include social perception, increasing the social information processing, responding to the skills, like somebody is talking to me, how should I take that? And how should I respond to that? If somebody is ignoring me, how should I respond to that? And affiliative skills, like relationships, how to maintain the privacy, how to maintain the boundaries, instrumental roles, interaction skills, and all these skills comes in a social skills training. You have the medications going on, you have the psychoeducation of the caregivers going on, and then is a social skills training. So all these things should go on a parallel note. If you do one after the other, then the amount of the or whatever effort you have put may not be 100% perfect. So you have to do all these things in a parallel way. That is the reason why when you're treating a patient with schizophrenia, a teamwork is a must. Because if you want the patient to come back to normalcy, this kind of a teamwork is very, very necessary. And evidence, there are a lot of papers, a lot of things in which social skills training along with psychoeducation has improved the quality of life of a patient. Ultimately, what we want is the patient to have a good quality of life. We don't want him to just sit on the bed, eat tablets, sleep, do the household work, and that's it. We want him to have a good quality of life. He should be happy. He should be doing his work, and he should be like a normal person. That's what the management of schizophrenia means. There are a lot of other self-management skills, recovery-focused interventions, which we have to like motivate them. We have to reducing the risk of relapse is in the patient's hand. And there are other recovery-focused interventions. The other last thing is supported employment services, which we usually the institutes like NIMHANS and AIMS PGI do, where there is a social work team who talk to the employers. They tell that, okay, there is a patient who has certain qualification. Why don't you give him a trial and test it, give him a job, just like a trial. And once the employer is okay, then they get employed, and that's how we support them with the employment. It's very it helps the patient to come out of schizophrenia very fast. It makes him feel confident that, okay, despite my symptoms, I'm able to work. Despite everything, I'm able to earn. I'm not dependent on my family members. So if we are able to do these things, the patient can come out of all the symptoms very fast and easily. So in conclusion, So with the management of schizophrenia, pharmacology is important, family involvement is involvement, social skills training, supported environment, employment, cognitive behavioral therapy. All these things, they reduce the relapse, they reduce the symptoms, they prevent the relapse of a person, improve the social skills. We can able to send them to the employment and reduce whatever the symptoms they have. So all these things. So we majority of the people feel that okay schizophrenia आ गया गोलियां दे दो ठीक हो जाएगा इसको therapy we give him the medications he sits in well therapy doesn't work for schizophrenia and all but pharmacology is only 70% of the things the rest 30% should be from the other things like training, supported environment, employment. All these things matter. If you want a person to with schizophrenia to be improved 100%, you want to manage 100%. All these things should be there in your management plan. So that's with that I would end my talk. Thank you. And these are few of the movies. If you are interested to see how schizophrenia is and all, or if you want to tell to the patients or psychoeducate them, these are the few movies which are English based on schizophrenia. So you can just take a photo of this and I will also share in the chat. Okay. Thank you everyone. And yes, sir.
Thank you, sir.
Thank you.
Thank you so much, sir. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you, sir. It was really very informative.
सर एक क्वेश्चन था हेलो पिछली बार जो सेशन हुआ था मैं किया था उस पे शेयर नंबर ये नहीं हुआ पॉइंट नहीं ऐड हुआ मेरे नंबर पे
अब थोड़ा जोर से बोलिए
जी
Sir, I have a question.
Yes,
Hello?
please.
Sir, if schizophrenia caused by cannabis drugs. Hello.
Hello.
सर जो स्किज़ोफ्रेनिया है वो जो ड्रग्स कैनबिस जो ड्रग्स है उसके अब्यूज अगर होता है तो उस कंडीशन में हम क्या कर सकते हैं पेशेंट के लिए
हाँ सो उस टाइम पे हमें गोलियां देना है फर्स्ट पहले यू ट्रीट द पेशेंट गिव द मेडिकेशंस दीजिए उनको फिर उसके बाद उनको काउंसलिंग करना है थेरेपी करना है क्योंकि कैनबिस वो वापस लेने की चांसेस है तो उसको हम मोटिवेशनल एनहांसमेंट थेरेपी जो हम डी एडिक्शन में करते हैं उसको हमें यहाँ पे लाके उसको कैनबिस क्यों लेना चाह रहा था वाज इट आउट ऑफ क्यूरियोसिटी से लिया या उसको वो कंटिन्यूअसली लेके जाने के लिए ये कर रहा था तो वो सब चीजों को हमें फोकस करना है
हाँ सर उसके साथ में ना मतलब मेरी फैमिली में है कजिन ब्रदर है जिसमें दिक्कत है तो उनको मतलब साइकियाट्रिस्ट के पास दिखाया था काउंसलिंग हुई मेडिसिन हुई सब चीज हुआ 3-4 महीने ठीक रहा देन उसके बाद जो उसका कैनबिस यूज जो होता है जिसको गांजा बोलते हैं हिंदी में उसका यूज और ज्यादा बढ़ गया तो अब उसको डालने की बात की गई है एंटी ड्रग अब्यूज सेंटर में जहाँ पे उसको रखा जाएगा ट्रीटमेंट दिया जाएगा हेलो
सर
ऐसे प्लेस ठीक रहते हैं क्या क्वेश्चन पूछते
कैनबिस या गांजा जो भी यूज करते हैं उससे डोपामिन का लेवल बढ़ जाता है वो डोपामिन अमाउंट बढ़ता है तो वो जब ट्रीटमेंट लेने के बाद लेवल नॉर्मल हो जाता है और वापस लेने के बाद वो जो डोपामिन जो रिलीज करता है कैनबिस के वजह से वो थोड़ा हाई हो जाता है उसके वजह से सिम्टम्स और थोड़े ज्यादा होने के चांसेस है
हाँ जी सर
मेडिसिन जो है
मेडिसिन के साथ उसको थेरेपी देना भी बहुत इम्पोर्टेंट
Okay. Thank you so much, sir.
Thank you, sir.
Sir,
Yes,
I
sir.
have a question.
Yes.
Sir, it's just out of agar if two conditions are comorbid, so let's say if a patient is having schizophrenic symptoms as well as PTSD symptoms or any other something like that. So is it necessary and PTSD or any mental health issue? तो is it something that हमें पहले schizophrenic symptoms के लिए treatment देनी चाहिए, उसके बाद PTSD पे focus करनी चाहिए, something like that in terms of therapy?
So it all depends on person to person. So you have to take the person into consideration. अगर PTSD से schizophrenia आया, schizophrenia से PTSD आया, what is the primary symptom? अगर PTSD patient is able to handle, अगर flashbacks हो रहे हैं, if you are able to do that, if he is able to recollect those kind of things. So, say for example, if you ask me, it all depends upon the patient. Patient आया schizophrenia से, मगर PTSD के symptoms मिले. अगर मैं PTSD का symptom therapy start किया, if it is increasing the schizophrenia symptoms, मैं PTSD को हाथ नहीं लगाऊंगा. I will not do PTSD thing. I will do worry only about the schizophrenia. Once schizophrenia कम हो गया, then I will start working on the PTSD.
Thank you, sir. Sir, I have a question.
Yeah.
Actually, sir, the pediatrician, they generally give the children as young as 4 to 5-year-olds that is risperidone for ADHD and sometimes autism. So my question is that will it be affect if suppose some child is taking risperidone for 5 to 10 years, will it be affect them and that make them schizophrenic or anything like that, because they don't have this and the pediatrician they are giving high dose of risperidone.
Yeah, very unlikely, ma'am. And no doctor wanted to use a patient medications, especially children. Okay, the reason the pediatrician is giving risperidone for the child might be to improve him, not to bring some other disorder. If
I have a question, sir.
When we get some other disorder, we will never start that medication first of all. Second thing, risperidone itself is an antipsychotic. So अगर risperidone दे रहे हैं तो उसको schizophrenia होने के chances बहुत कम हैं. There might be some other side effects. So if the parents feel that okay 5 साल से 10 साल से ये डॉक्टर यही गोली दे रहा है, तो दूसरे डॉक्टर के पास सेकंड ओपिनियन के लिए भेज दीजिए. There might be a chances that उनका experience दूसरा जैसा रहा होगा, वो change कर सकते हैं. So it all depends on doctor to doctor, and no doctor wantedly writes medications. No doctor wantedly want the patient to have side effects. We all are worried about that. Okay, so don't worry.
Good evening, sir. Hello. Good evening, sir.
Hello.
Yeah.
I want first session evolution link, but I just had a net problem in first session time. Is it possible you can activate first session evolution link? First session evolution link. Hello, ma'am. Please send the first session evolution link.
Go ahead. Please ask.
नो लॉन्गर एक्सेप्टेंस लिख रहा है सर फास्ट इवैल्यूएशन लिंक में. फास्ट सेशन इवैल्यूएशन लिंक में नो लॉन्गर.
Sir, bye. I am leaving.
हेलो सर. हेलो.
Yeah.
मैं बंगाल से बोल रहा हूँ सर. फास्ट एवोल्यूशन जो लिंक था उसमें सबमिट किया है मगर मार्क्स नहीं पर.
अच्छा, वो आपको श्रवण सर बता देंगे.
I think that question is not related to meeting. From organizers, we'll send you the link evaluation.
Sir, I have one question.
Sir,
I have one question.
Good evening, sir.
yes, Sandhya.
Sir, my question is, अगर some cases में सर schizophrenic patient है और उसमें कुछ ट्रैंकुलाइजर जैसे डॉक्टर्स प्रिस्क्राइब्स करते हैं कि ये मेडिसिन देनी है, क्वांटिटी ये, पर सर मोर केसेस में क्या होता है कि कुछ schizophrenic जो पेशेंट्स होते हैं वो उसको लेना ही नहीं चाहते हैं. तो उस कंडीशन में एज ए फैमिली जो हम लोग होते हैं उस कंडीशन में जैसे वो लेना ही नहीं चाहते को फेंक देता है ना, रिफ्यूज कर देता है और उसका समटाइम्स बिहेवियर जो है फॉर एग्रेसिव सा हो जाता है और डिप्रेसिव में. है ना, और सर वो नींद ही नींद में रहता है, तो उस कंडीशन में हम उस पोजीशन में क्या क्या टेक्निक्स यूज कर सकते हैं एज फैमिली मेंबर्स?
एज ए फैमिली मेंबर्स एक है कि आप एक जो साइकेट्रिस्ट ने दिया उसके वजह से ही इज नॉट फीलिंग बेटर, you can show it to some other you can show it to some other psychiatrist. Second thing, if the patient is not, गोली खाने में बहुत कुछ दिक्कत हो रही है, वो नहीं ले रहा है, तो लॉन्ग एक्टिंग इंजेक्शन है जिसको महीने में एक बार लेना है, वो इंजेक्शन दे सकते हैं। ऐसे भी अभी रिसेंटली 6 महीने में एक बार देने का एक इंजेक्शन आया हुआ है, वो भी दे सकते हैं। अगर ये सब भी नहीं हो रहा है तो कभी कभार थोड़े बहुत सिरप्स है जो हम खाने में मिला के दे सकते हैं, मगर वो थोड़ा इलीगल रहेगा। लीगली इट विल बी बेटर अगर पेशेंट अपने आप लें, अगर हम मिला के देंगे तो इट्स अगेंस्ट द ह्यूमन राइट्स ऑफ द पेशेंट।
Thank you so much, sir. Thank you.
अगर उसको गोली लेनी
Sir, I have a question. Sir, if a person is having medicine to cure epilepsy, then is it okay to take medicine of schizophrenia along with?
Yeah.
Is there any side effect?
No, schizophrenia की गोलियां कौन से भी गोलियों के साथ ले सकते हैं। अगर फीवर आया, हेडेक आया या कुछ भी और प्रॉब्लम है, लिवर का प्रॉब्लम है, कुछ भी है, इन गोलियों का और उन गोलियों से कोई लेना देना नहीं है, कोई इंटरेक्शन भी नहीं है। देयर आर आल्सो सम ऑफ माय पेशेंट्स जो स्किज़ोफ्रेनिया की गोलियां खाते हैं और दारू भी पीते हैं, ऐसे भी थोड़े पेशेंट्स हैं। सो जैसा ऐसा कोई इंटरेक्शन नहीं रहता है। और ये खाना ऐसा पर्टिकुलर खाना रिस्ट्रिक्शन नहीं है, एवरीथिंग बहुत लोगों को ये रहता है।
आप इसको लर्न करके रखना, ठीक है, अच्छे से रिवाइज करके रखो सारा। मैम कल आपका टेस्ट भी लेगी और कल अच्छे से कराएगी, ठीक है।
I have one question.
Yes, Nishita.
Yeah, Nitin, thank you for your wonderful presentation.
My question here is that, sir, in cases of schizophrenia, it's usually during psychoeducation, what we say is that the medication should be taken. Uske baad after the symptoms reduce, then only we should give CBT or any other psychotherapy. So my question here is there any can both simultaneously keep medications भी दे दे और साथ साथ में psychotherapy भी दे दे, irrespective of whether it is schizophrenia or any condition?
So depends upon the symptom severity. अगर उसको active hallucinations हो रहे हैं, if he is actively listening to the voices, वो आपके CBT सेशन में नहीं बैठ पाएगा। तो वो symptoms थोड़े कम होने के बाद you can do the CBT. Meanwhile, what you can do is you can do the psychoeducation for the caregivers. जब तक symptoms थोड़ा बहुत कम हो जाता है, वो patient is confident कि मैं यहाँ पे बैठ के I can talk to you, you can start the therapy. So it all depends upon your individual decision. It all depends upon your individualness, uniqueness in the patient.
Okay, sir. Thank you.
Yeah, any questions?
Hello, sir. Sir, good evening, sir. Sir, more,
Yes,
sir, one more question, sir. Sir, ये मेरा क्वेश्चन अलग है। मेरा क्वेश्चन है जो हम लोगों के, आई एम ए स्पेशल एजुकेटर सर। सर, मेरा क्वेश्चन है जो हम लोगों के पास में सम मोर केसेस इज ADHD and ESD. हेलो,
हाँ बोलिए।
हेलो, हाँ सर, उन केसेस में क्या होता है जो हमारे में पेरेंट्स आते हैं और वो उनको साइकेट्रिक के पास में लेके जाते हैं, तो उस केसेस में उनके हाइपर एक्टिविटी को रिड्यूस करने के लिए उनको ट्रैंक्विलाइजर देते हैं। सम और कुछ डोज तो बहुत हाई होती है, जिसे लेने के बाद में क्या होता है कि बच्चे का क्या होता है, स्लीपी रहता है एंड रेस्टलेस बिहेवियर हो जाता है। तो मेरा क्वेश्चन है कि क्या जो हाइपर एक्टिविटी है उसको रिड्यूस करने के लिए कुछ केसेस में जो हमारे क्लिनिकल साइकोलॉजिस्ट हो गए, हमें उनको थेरेपी के लिए एज ए पेरेंट्स को बोलना चाहिए या कि उनको ट्रैंक्विलाइजर कंटिन्यू देनी चाहिए? सर,
आपका क्वेश्चन आप शॉर्ट कर सकते हैं, बहुत लंबा क्वेश्चन पूछा आपने।
हाँ सर, माय क्वेश्चन कि जो ADHD एंड ESD केसेस होते हैं उनको एज ए काउंसलिंग सेशन की रिक्वायरमेंट ज्यादा होती है या एज ए ट्रैंकुलाइजर की?
ADHD में गोलियां भी काम करते हैं और लॉट ऑफ बिहेवियरल टेक्निक्स भी है। ASD में अगर ऑटिज्म में देखेंगे तो लॉट ऑफ बिहेवियरल थेरेपी ज्यादा देना पड़ता है, और ADHD में गोलियां भी चाहिए और बहुत सारे बिहेवियरल टेक्निक्स भी है जो आपको पेरेंट्स को सिखाना है, पेरेंट्स के साथ ज्यादा टाइम बिताना है। हाँ, अगर आपको लग रहा है कि पेशेंट लाइक बच्चे को बहुत हाई डोज में दे दिया, बच्चा बहुत सो रहा है और कुछ काम नहीं कर रहा है, आप अपना बिहेवियरल टेक्निक अपना बिहेवियरल टेक्निक कीजिए। पेरेंट्स को सिखाइए कि अगर बच्चा अगर ADHD है तो हाउ टू मैनेज दैट। अगर ASD में अगर वो अपना काम नहीं कर रहा है तो डिफरेंट टाइप ऑफ ABA थेरेपीज उनको टीच कीजिए। सो अगर साइकोलॉजिस्ट का सपोर्ट साइकियाट्रिस्ट को रहेगा, इस बिहेवियरल टेक्निक से आप कुछ थोड़े 2 कदम आगे जा रहे हैं तो दैट गिव्स अस द फ्रीडम टू रिड्यूस द डोज ऑफ द मेडिकेशंस। So as I said, it's a teamwork. You can't play alone.
Hello?
I can't play alone. It's a cricket match. आप
I have a question, sir.
खड़े होके आप छक्के नहीं मार सकते, दोनों तरफ मारना।
Sir, thank you
Hello?
so much. Such a wonderful session, sir. Thank you
I
so
think
much.
Dr. Nitin, I think it's time for
Yes, sir.
Okay, no, any questions?
I have a question, sir. Hello?
We will share the mail ID of Dr. Nitin. You can share it by means there is a time limit. Or okay, no, we are having another session. Okay, no, physical
Hello?
session from our side. Okay, no. So, Dr. Nitin, thank you for your wonderful and brief presentation. And though you
Yes,
are
sir.
busy practitioner, you have given your time and come here.
Hello, sir. Hello.
And so many of us, all the CRE participants have attended through online, and many of our students and staff, they have attended through physical mode. And thank you, Nitin, for your wonderful
Thank you, sir.
presentation. And
Thank you for that. Yes, sir. Thank you for the
Hello,
opportunity.
sir.
Thank you.
Hello, sir. One question, please.
I think Nitin sir has left. Anything? Our organizers will share mail.
Good evening, sir. Sir.
Hello. Hello. Hello, sir. Anyone can hear me?
Yeah.
Hello.
That is, sir, are you there?
Yes.
Sir?
Sir, hello. Where is our certificate, sir?
Yeah, hello.